we will talk about the umbilical blood sampling. If you want to sample the umbilicus, the sampling site should be standardized and that umbilical artery should be sampled at the site nearest to the fetus. Isolated of the vessels by the double clamp the cord at birth. We should double clamp 10 cm of umbilical vessels and we will take sample for artery and vein. When you look to this picture, which one is the correct, A or B? B is the correct picture. Because if you go with A, the artery and vein, they are near to each other and you might penetrate from one vessel to another. But if you go 45-degree, will increase the chance of sampling the artery and vein. Don't leave the umbilical blood vessels hanging to the placenta. This is no wrong practice. So you have to clamp 10 centimeters of the umbilical vessels and you keep it aside, then you extract the blood. Remember that small changes in umbilical pH occur within 60 minutes of the delivery, and over 60-minute cord, artery, or venous pH can fall by more than 0.2 unit if it is continue attached to the placenta. So these changes are not observed if the cord is double clamped at birth, isolating segment of the cord blood from both the placenta and the environment. 60-minute pH fall by more than 0.2 unit. Double clamp the cord, pH doesn't change. There are many factors that influence the cord blood value, like fetal physiological factors, fetal hypoxia, asphyxia, duration of hypoxia, fetal anemia, infection, fetal cardiac dysfunction, and fetal growth restriction. There is placental factor like placental insufficiency, placental abruption, cord compression and prolapse, and uterine hyperstimulation. Intrapartum or labor factor like length of the second stage, mood of the delivery, uterine tachysystole, and maternal hypotension. Maternal factor also like acid-base disorder, medication, diabetes, hypertension, preeclampsia might affect the fetal cord value. Sampling and handling factor like delay in sampling analysis, cord not double clamped, or air bubble in the syringe, and the venous versus arterial blood. Interpretation of arterial blood gases. By looking to this parameter, the pH, the PCO2, the base deficit, and the bicarbonate, you can have an idea about what is going on during labor. So by looking simply to this, which one of these parameters you would consider an ideal parameter for estimating the cumulative exposure to the hypoxia? Determining the pH is going to determine the acidosis or alkalosis, whereas the PCO2 determining any respiratory components, the bicarb determining any metabolic component, and the base excess determining any metabolic components. So by looking to this, you can say that if the pH is less than 7.2, that this means there is acidosis. If there is a CO2, it is increased, that means there is a respiratory acidosis. And if there is base deficits increase, combining with the reduction in the bicarbonate, that means there is a compensatory metabolic acidosis process is going on. Understanding the pH-base excess and acid accumulation. The change in the hydrogen ion concentration associated with fall in the pH from 7 to 6.9 is almost twice that which associated with fall in the pH from 7.3 to 7.2. Because it is a logarithmical term, it doesn't give a linear measure of acid accumulation. pH is not an ideal parameter for estimating the cumulative exposure to hypoxia, where base excess provided a more linear measure of the degree of accumulation of metabolic acidosis. So if you are going to use a parameter to measure the accumulation of acidosis, better to use base excess. We are talking about the base deficit. Metabolic acidosis results in excessive production of acid and decrease in the base. The base deficit doesn't significantly change during respiratory acidosis, where most of the study mentioned that the base deficit was the most important variable for the predicting neonatal morbidity. The recommendation that the realistic value for the defining pathological acidemia is 7, a pH equal to 7, where the base deficit of more than 12 is reasonable threshold for the prediction of a neonatal complication. There is several factors influence cord blood gases. There is normal arterial blood gases resulted closer to the normal adult value in certain situations, like infant birth to the multiparous woman where there is short labor, elective cesarean section, the patient she is not passing through labor. Chorioamnitis doesn't appear to influence cord blood pH or base excess, where metabolic changes occur in the repeated uterine contraction of normal labor, in twin pregnancy due to the stress, regional anesthesia, particularly spinal anesthesia, associated with increased incidence of cord blood acidosis, weakly positive correlation between the cord pH and umbilical cord length, number of coil, and number of vascular coil per centimeter. Remember that Remember that uncomplicated labor changes base excess by around 3 millimole per liter all over, where in normal second stage of labor, changing it by around 1 millimole per 1 hour. In contrast, base excess changing by around 1 millimole per liter per 30 minutes during prolonged period when there are repeated fetal heart rate deceleration. So the most profound fetal compromise, such as that associated with a terminal bradycardia following acute uterine rupture, changes base excess by 1 millimole per 1 liter per 2 to 3 minutes. So if we count how many minutes it's required to develop base excess associated with a birth asphyxia. To develop metabolic acidosis, assuming that the fetus is enter in labor with zero base excess, and he have the bradycardia, whether due to ruptured uterus or cord prolapse, it will require a 20-minute, minimum of 20 minutes that the base excess will reach from 0 to 10. What that mean? That mean to reach to metabolic acidosis, it's required 20 minutes. And to enter above the 12, which is associated with the neurological deficits, you require 24 minutes. This is more or less plus or minus. So this is the timeline where you have to run whenever there is uterine rupture or bradycardia, suspected uterine rupture, severe abruption placenta, or cord prolapse. The umbilical cord can become obstructed before birth, like knuckle cord or cord prolapse. Restriction of umbilical blood flow causes progressive widening of the difference between umbilical artery and venous pH, CO2, and oxygen than those without evidence of cord compressions. In contrast, arterial to venous differences are small, where there is impairment of the maternal perfusion of placenta, such as the cases of abruption placenta. So in abruption placenta, both artery and vein will be affected and depriving the oxygenation, and you can see small difference between the artery and the vein. Goodman et al. Reported in his study of 69,000 term delivery with a cord blood gas measurement, no infant was alive born with the pH 6.6. So he comparing the core pH to the hypoxic ischemic encephalopathy. When the core pH is 7, the HIE is 12%. When the core pH is 6.9, HIE is 33%. Core pH 6.8, HIE is 60%. And core pH is 6.7, HIE is 67%. From this picture, we can say that the more the core pH will be lower, the more the effect, the consequences of hypoxic ischemic encephalopathy. Here is the after-birth normal fetal cord blood pH gases value, the venous and the artery, and you can see that the pH in the vein it is either 7.25 to 7.35, whereas in the artery it's 7.2 to 8. Remember that the artery in the cord, it's carry the deoxygenated blood which is coming from the fetus, whereas the vein is the one which is carry the oxygenated blood which is coming from the placenta toward the fetus. The base deficits here, it is 0 to 5 in the vein, where it is 0 to 10 milliequivalent per liter in the artery, depending in the situation, depending in the labor, the length of the labor, the progressive labor, and so on. The CO2 also almost the same, and the oxygenation, there is no much big difference, and we didn't reflect on it dramatically. When we are looking for abnormal fetal cord blood pH and gas value, you find that the pH less than 7.25 for both. There is no significant difference in the oxygen CO2. The main difference between respiratory acidosis and metabolic acidosis is the base deficit. The base deficit in respiratory acidosis less than 10 milliequivalent per liter, where it is for metabolic acidosis, it is more than 10 milliequivalent per liter. By defining the umbilical artery base deficit at birth as mild if the base deficit is between 4 and 8, whereas moderate between 8 and 12, and severe if it is more than 12. If it is more than 12, associated with increase in the risk of hypoxic ischemic encephalopathy. The final pH of the blood is determined by the proportions between the oxygens, the carbon dioxide respiratory component, and the bicarb metabolic component. These constructs suggested that when metabolic acidosis is found, the time of the hypoxic insult cannot be estimated. In contrast, when the respiratory component is found, the onset of hypoxic insult can be established because these components cannot last more than 20 to 30 minutes. So the presence of respiratory components, the respiratory acidosis, it's telling us that this started within the last 20 to 30 minutes, whereas the presence of metabolic components, it cannot estimate the time. Do you want to take umbilical artery or vein or both? Sampling the artery alone versus sampling the artery and vein. The umbilical vein carry oxygenated blood to the fetus, whereas the umbilical artery, the two umbilical artery carry deoxygenated blood in the opposite direction from the fetus to the placenta. So arterial blood reflecting fetal acid-base balance with low pH and CO2 and higher PCO2 than venous blood, which is reflected the combination of the fetal and the maternal acid-base status. So it's widely accepted that umbilical artery provided the most accurate information for the detection of the fetal and neonatal acid-base status. But remember, you need both, proving that if it is normal value, that this is the real value. It is not venous. It's not venous blood. It is arterial blood. As we mentioned, we have to stress that the umbilical artery provided the most accurate informations for detection of fetal and neonatal acid-base status. why it is important to take artery and venous blood sampling. In their analysis, very large arterial venous difference, whether we are talking about the pH, we are talking about the CO2, or talking about the base excess, in normal value pH is unable to excluding the possibility of significant arterial acidosis. So a large arteriovenous base excess difference may indicate an acute event like abruptio placentae, like cord prolapse, where the small arteriovenous base excess difference is more likely to indicate the chronic acidosis course, like cases of the fetal growth restriction or chronic acidosis courses.